Have you ever jumped when an unexpected loud noise went off?
Oh, absolutely.
Right. Or maybe you flinched when someone suddenly tapped your shoulder from behind while you were like deep in thought.
Yeah, happens all the time.
Of course you have. I mean, we all have. You feel that sudden rush of adrenaline, that quick intake of breath, the immediate tensing of your muscles.
Exactly.
And it is an entirely normal survival mechanism. It's your body's built-in alarm system doing exactly what it was designed to do, right?
Yeah, evolutionarily speaking, that millisecond flinch kept our ancestors alive when, a predator snapped a twig in the brush.
It's crazy how fast it is.
It really is. The signal actually bypasses your slow, conscious thinking brain completely. It goes straight to your motor neurons. So
Yeah.
you move before you even really know what you're moving away from.
Wow.
It is a beautifully efficient piece of biological engineering. I mean, a normal startle is simply a brief, sudden reaction to an unexpected stimulus,
Like a gunshot nearby or
right? A gunshot, a car backfiring, a sudden, blindingly bright light in a dark room. Your body reacts, it assesses the threat, and then it just resets.
just healthy.
Exactly. That is your nervous system functioning perfectly.
So I want you to imagine a scenario for a moment. Think about this. What if that simple, gentle tap on the shoulder threw you completely off balance?
Right.
What if that tiny, almost imperceptible stimulus, a stimulus that poses absolutely zero threat to you, sent your body into such a violent, uncontrollable physical reaction that you, went crashing to the floor?
Yeah, that changes the entire paradigm right there.
It does.
When the system designed to protect you suddenly becomes the thing putting you in immediate physical danger, we cross a very specific threshold in neurology.
So, welcome to the deep dive. Today, we are stepping into a fascinating and honestly sometimes baffling neurological condition known as pathologic startle.
It's a really complex topic.
It is. We're going to explore what happens when the human startle reflex goes completely rogue. We'll look at how doctors piece together the mystery of a hyperactive nervous system, the bizarre underlying causes that range from, well, microscopic brain damage to genetic mutations.
And even how culture and geography can completely alter the way a human being reacts to being surprised.
Yeah, which is just wild. But to really understand this, we have to precisely define where that line is drawn between a normal jump and a pathologic one.
Right. In medicine, a startle is only considered pathologic if it meets three very strict criteria.
Okay, what are they?
It must be severe, it must be frequent, and this is the most critical piece for a diagnostician. It must be provoked by relatively minor stimuli.
Provoked by relatively minor stimuli. Okay, I want to build an analogy here for you listening to help conceptualize this, because it's not just about the size of the reaction, it's about what triggers it.
Exactly, the trigger is key.
So imagine your nervous system is a car alarm. If someone throws a heavy brick through the window of your car, the alarm blares.
Which makes sense.
Right, that makes total sense. The brick is the gunshot or the bright flash of light. That is a normal startle. But pathologic startle isn't just a louder alarm.
No, not at all.
Pathologic startle is when a gentle autumn leaf falls onto the windshield, and that microscopic, weightless impact triggers a blaring, system-wide, ear-piercing siren.
That's a great way to put it. The threshold of the stimulus, the leaf falling versus the brick, is exactly what a doctor is looking for.
Because it tells us something is fundamentally broken.
Yes. It tells us that the nervous system's internal gating mechanism is offline. You see, the brain is constantly receiving thousands of sensory inputs every second.
Like the feeling of your clothes on your skin.
Right, or the hum of the refrigerator or a breeze in the air. A healthy brain filters almost all of that out. It essentially says, ignore that, it's not important.
But when it doesn't?
When a minor stimulus, like a tap on the shoulder, triggers a massive physical reaction, it means those internal shock absorbers have completely failed. The brain is treating a leaf like a brick.
Okay, let's bring this out of the abstract and look at what this actually does to a human being. Let's do a little clinical teaching session here and visualize a patient.
Okay, let's set the scene.
They are sitting in a consultation room. It's quiet. They are just sitting in a chair, waiting for the doctor. A nurse walks by and, just to get their attention, lightly taps the patient on the shoulder.
The leaf hitting the windshield.
Exactly. Let's break down the exact sequence of the physical reaction, millisecond by millisecond. What actually happens?
So the reaction follows a very specific, almost mechanical progression. First, the eyes blink violently.
Okay.
And this isn't a normal, casual flutter of the eyelids. It is a forceful, sudden, involuntary closure of the orbicularis oculi muscles. The body is instantly trying to protect the visual center.
Wow. And then second, the face contorts into a visible grimace, like the facial muscles just pull incredibly tight.
Right. Third, there is a sudden flexion of the neck and the trunk. The patient's entire core basically crunches inward, folding forward as if they're bracing for a physical blow to the abdomen.
Man. And fourth, the arms experience simultaneous flexion and abduction.
Yes.
Wait, let's pause and translate that specific movement because I want you to picture this clearly. Flexion means bending the joints, right? Pulling the arms inward toward the body.
Correct.
But abduction means moving the limbs away from the midline, away from the center of the body. So their arms are bending at the elbows, but they are also flying outward and upward away from their torso.
Exactly. It is a highly complex, chaotic misfiring of motor signals.
That sounds intense.
It is. The biceps might be contracting to bend the arm, while the shoulder muscles are simultaneously firing to throw the arms outward. It is an intense, uncoordinated burst of electricity just flooding the muscular system.
And then finally, because of the violent combination of all these simultaneous movements, the forceful grimace, the sudden crunching of the trunk, the arms flying up and out, the patient's center of gravity is completely destroyed.
Right. They can't stay upright.
They are thrown off balance. The result is a fall. They crash to the floor of the consultation room. And all of this just from a polite tap on the shoulder.
When you slow it down and really visualize the biomechanics of it, you begin to grasp the severity of the condition.
It's incredibly dangerous. I mean, think about trying to navigate your daily life like that.
It would be nearly impossible.
A dog barks half a block away, or a door closes a little too loudly in your office, someone brushes past you on the subway, and suddenly your body violently contorts, your arms fly out, and you are thrown to the concrete.
Yeah, you couldn't drive a car safely. You couldn't even safely walk down a flight of stairs.
It is profoundly disabling. So, seeing this intense reaction, the doctor must now figure out why it's happening. The symptom is glaringly obvious.
Oh yeah, you can't miss it.
But the etiology, the underlying medical cause, is a puzzle that needs to be solved systematically. So if a patient is picking themselves up off the floor after the severe reaction, how does a doctor even begin to figure out what caused it? I mean, you can't just tell them not to flinch.
No, you definitely can't. And the very first step in diagnosing the root cause of pathologic startle actually has nothing to do with the startle itself.
Wait, really?
Really. The doctor must observe the patient between the episodes, when they're just sitting there, undisturbed, recovering in the chair.
Okay, looking for what?
The critical question is this: is there a persistent state of autonomic hyperactivity?
Autonomic hyperactivity. Okay, meaning the autonomic nervous system, which is the background operating system that controls your heart rate, your blood pressure, your fight or flight response, is stuck in the on position.
Precisely. We are looking for observable signs that the patient's nervous system is constantly revved up.
Like an engine idling too high.
Exactly. Clinically, there are two primary indicators of this baseline state: chronic anxiety and a greater or lesser degree of tremulousness.
Tremulousness meaning shaking, tremors, a physical vibration of the body, like when you've had way too much coffee and your hands won't stay completely still.
Yes, it's a visible, physical manifestation of an overstimulated nervous system. The neurons are firing so rapidly in the background that it leaks out as a subtle, continuous tremor.
Okay, to help organize this medically, let's create a mental model. Because clinical reasoning is all about organizing information. Imagine we have two buckets.
Okay, two buckets.
Bucket number one is for patients who exhibit that persistent autonomic hyperactivity. They are anxious, they are tremulous, they are visibly vibrating with nervous energy when they are just sitting still.
Right.
And then bucket number two is for patients who are completely calm between startles. Their baseline is totally normal, no anxiety, no tremors. The doctor's entire diagnostic path depends on which bucket the patient falls into.
It is the ultimate fork in the road for diagnosis.
Okay, let's unpack these buckets, starting with bucket one.
Well, the literature notes that this bucket, patients with persistent autonomic hyperactivity, actually contains the most common causes of pathologic startle.
Let's run through the conditions that fill bucket one and then look at the mechanics behind them. First, we have post-traumatic stress disorder, or PTSD.
Yep.
Second, generalized anxiety disorder, or GAD. Third, alcohol, or sedative hypnotic withdrawal. And fourth, the use of sympathomimetics, like excessive caffeine.
The common thread linking all of these is a systemic chemical or psychological hyperarousal.
Okay, let's look at PTSD and generalized anxiety disorder first.
Sure. In these conditions, the brain's fear center, primarily the amygdala, is hypervigilant. It is constantly scanning the environment for threats.
Because of past trauma or chronic anxiety.
Exactly. The brain has essentially learned that the world is inherently dangerous.
So the amygdala is constantly whispering to the brainstem, get ready, something bad is about to happen, stay on high alert.
Exactly. The system is primed. The baseline tension in the muscles is higher. The adrenaline levels circulating in the blood are elevated.
Right.
So when that minor stimulus occurs, the tap on the shoulder, the brain doesn't have to ramp up to a startle. It's already like 90% of the way there.
Oh, wow.
The stimulus just pushes it over the edge into a massive physical reaction.
Yeah, that makes a lot of sense for trauma and anxiety. But what about the withdrawal aspect?
That's a fascinating mechanism.
Because alcohol and sedative hypnotics like sleeping pills or certain anti-anxiety meds, those are depressants. They slow the brain down. How does withdrawing from them cause you to jump out of your skin?
This requires us to look at how the nervous system maintains homeostasis, or internal balance. Your brain operates on a delicate balance of inhibitory neurotransmitters, which calm things down, and excitatory neurotransmitters, which rev things up.
Okay.
The primary inhibitory neurotransmitter is called GABA.
GABA, the brain's natural braking system.
Exactly. When a person consumes a depressant like alcohol or a sedative, those substances enhance the effect of GABA. They press down hard on the brakes.
Makes sense. That's why you get sleepy or relaxed.
Right. Now, if a person consumes these substances chronically over a long period, the brain realizes it's moving too slowly.
It's trying to maintain that homeostasis.
Yes. To compensate, it downregulates, it physically removes some of its GABA receptors, and it increases its excitatory chemicals, like glutamate, to try and keep the engine running.
Oh, I see. So the brain is essentially pressing harder on the gas pedal because the chemical emergency brake is constantly pulled up.
That is the perfect way to conceptualize it. The nervous system physically alters its own structure to fight against the depressant.
Okay.
Now imagine what happens when the patient suddenly stops drinking alcohol or stops taking the sedative.
They go into withdrawal, they rip the emergency brake off, but the brain is still pinning the gas pedal to the floor.
Precisely. The depressant is gone, but the brain's internal chemistry is still highly excitable.
Because those extra receptors are still there.
Yes, it takes time for the receptors to rebuild and the balance to restore. During that withdrawal window, the nervous system is left in a profoundly overactive, hypervigilant state. The inhibition is gone. Hence, the patient experiences intense anxiety, severe tremulousness, and a drastically lowered threshold for the startle reflex. The leaf hits the windshield, and the over-revved engine explodes.
And that ties perfectly into the fourth cause in bucket 1, sympathomimetics. The name literally means substances that mimic the sympathetic nervous system, the fight-or-flight system.
Right, excessive caffeine, amphetamines, certain decongestants.
They just force the system to rev up.
Exactly. These drugs artificially flood the system with adrenaline and noradrenaline. They bypass the need for an external threat and just manually flip the switch for autonomic hyperactivity.
Okay, so bucket 1 makes total sense. The engine is running way too hot, either from psychological trauma, chemical withdrawal, or stimulants. The whole system is vibrating.
Right.
But what about bucket 2? These are the patients who are perfectly calm, no tremors, no background anxiety. Their baseline is totally normal.
Yes, the calm baseline.
But they still have this violent, crashing startle response to a minor stimulus. If the system isn't flooded with adrenaline, what is causing the reaction?
This bucket is deeply fascinating because it points away from a systemic chemical imbalance and points directly toward structural or genetic defects.
So the machinery itself is broken in very specific places.
Exactly. The most common cause in this second bucket is a genetic condition called hyperaplexia.
Hyperaplexia sounds like exactly what it is, hyperstartle.
Yes, it is often referred to as startle disease. The literature notes two key characteristics. Its onset can be in infancy, or it can present later in life, and it is a familial or genetic disorder.
It is literally woven into the patient's DNA.
It is.
So what exactly goes wrong in the DNA to cause this?
Well, remember how we talked about GABA being an inhibitory neurotransmitter in the brain?
Yeah, the brakes.
Well, in the brainstem and the spinal cord, the primary inhibitory neurotransmitter is actually a chemical called glycine.
Okay, glycine.
Glycine's entire job is to tell the motor neurons in the spine to calm down, to relax the muscles. In hyperaplexia, there is a genetic mutation that causes a defect in the glycine receptors.
Oh, so the chemical signal to calm down is being sent, but the receptor on the other end is deaf to it.
Exactly. The spinal cord doesn't receive the inhibitory message. So when a normal startle signal comes down from the brain, there is nothing there to dampen it or shut it off.
And they just lock up.
The muscles contract violently and rigidly. In infants with this condition, a simple tap on the nose can cause their entire body to go completely stiff as a board.
That's terrifying for a parent.
Absolutely. It is a profound failure of the nervous system's internal braking mechanism at a genetic level.
That is incredible. So that's the genetic side of bucket two. But there are also structural physical causes, right? The text points heavily to brainstem lesions as a cause of pathologic startle.
Yes, the brainstem is the critical geography for this entire reflex. Specifically, we need to look at two distinct regions of the brainstem, the pons and the upper medulla.
Okay, let's map this out for a second for you visualizing this at home. The brainstem is the stalk at the base of the brain that connects the cerebrum up top to the spinal cord down below.
Right. And through that stalk runs a dense network of nerves called the reticular formation.
The reticular formation.
Yes, this is the processing center for the startle reflex. Auditory and tactile signals, the loud noise or the tap on the shoulder, enter the brainstem and are immediately processed here before they even reach the conscious cortex.
That's super fast.
Exactly. If this area is structurally damaged, the reflex goes haywire.
So what kind of damage are we talking about? How does the pons or the medulla actually get injured?
Let's start with the pons. The literature notes that an infarction can cause pathologic startle.
An infarction.
Yes, which is tissue death due to a lack of blood supply. Essentially, a localized stroke right in the middle of the pons.
Got it.
A blood clot blocks a tiny artery, oxygen is cut off, and a specific cluster of neurons dies.
So a tiny stroke in the exact wrong place.
Yes. Another cause in the pons is a plaque from multiple sclerosis, or MS.
Okay.
MS is a demyelinating disease, and demyelinization is also explicitly listed as a cause of damage in the upper medulla.
Wait, let's break that down. Myelin and demyelinization. How does that cause a massive physical flinch? I mean, I need to understand the mechanics here.
A great question.
Because if an MS plaque is just a tiny localized spot of damage in the brainstem, how does that trigger a violent, full-body reaction? The math doesn't seem to add up. A tiny spot of damage causing the arms to fly out and the body to crash to the floor.
It requires us to understand how electricity moves through the body. Think of the nerve fibers running through the brainstem as electrical wires.
Okay, wires.
To ensure that the electrical signal travels fast and doesn't leak out, those wires are wrapped in a protective, fatty insulating layer called myelin.
Just like the rubber coating around a copper wire in a lamp.
Exactly. Now, diseases like MS cause the body's immune system to attack and destroy that myelin. That is demyelinization.
It strips the insulation off.
Right. It strips the rubber insulation off the wires in the brainstem, leaving them bare and exposed.
Oh, I see where this is going.
Now, think of the startle processing center in the brainstem, like a complex electrical breaker box or a surge protector.
A surge protector, I like that.
A normal sensory input, a gentle tap on the shoulder, is a tiny electrical current. In a healthy system, the insulated wires carry that current cleanly to the right place, the surge protector handles it, and the brain realizes it's just a minor touch.
But with demyelinization...
With demyelinization or with tissue death from an infarction, that surge protector is structurally broken. The bare, uninsulated wires are packed tightly together.
And the electricity jumps.
Exactly. When that tiny electrical current from the tap on the shoulder enters the damaged area, it doesn't travel cleanly. It short circuits. It arcs across the bare wires.
Whoa.
It amplifies uncontrollably. A tiny spark sets off a massive electrical fire that surges straight down the spinal cord, causing every motor neuron to fire at once.
The surge protector is fried, so a 1-volt tap turns into a 10,000-volt muscular explosion. That makes total sense.
Yeah.
The localized damage breaks the containment system.
Exactly. And there is one more structural cause in this area. Both the pons and the medulla can be physically compressed by an ectatic artery.
Ectatic, meaning an artery that is abnormally dilated, swollen, or stretched out.
Right. Sometimes a blood vessel near the brainstem becomes enlarged and tortuous. It begins to physically press against the delicate tissues of the pons or medulla.
Just leaning right on it.
Yes. And with every single heartbeat, that dilated artery pulsates and mechanically pounds against the startle circuitry.
Oh, wow.
It irritates it, compressing the nerves and causing that exact same short circuit effect.
So we have strokes, MS plaques stripping the insulation, and pulsating arteries physically crushing the brainstem. All of those fall into bucket 2, a normal baseline, but a damaged surge protector. Are there any other brain insults that can cause this?
The literature mentions a few other severe, more global insults to the brain that can lead to pathologic startle. There is posthypoxic, ischemic encephalopathy.
That's a mouthful. Okay, post-hypoxic means after a lack of oxygen. Ischemic means restricted blood flow. Encephalopathy means brain damage.
You got it.
So this is severe brain damage from suffocation, or maybe cardiac arrest where the brain didn't get blood for several minutes.
Correct. The massive loss of oxygen causes widespread death of neurons, particularly in the cortex.
The thinking part of the brain.
Right. And the cortex normally provides top-down inhibition to keep the brainstem reflexes in check. When the cortex is damaged by hypoxia, the brainstem is left unmonitored and overreactive.
It's like the manager of the factory is knocked out, so the workers on the factory floor, the reflexes just run wild.
That's a very good way to look at it. The literature also notes traumatic brain injury, or TBI, which can cause shearing forces that tear the microscopic wiring between the cortex and the brainstem.
Which would also cut off that top-down inhibition.
Exactly. And finally, Creutzfeldt-Jakob disease, or CJD.
CJD, that is a prion disease, right?
Yes, a fatal, rapidly progressive neurodegenerative disease. Prions are essentially misfolded proteins.
Right, they fold wrong.
Normal proteins in the brain somehow become twisted into an abnormal shape. And the terrifying thing about prions is that they act like a template.
How so?
Well, when a misfolded prion bumps into a healthy protein, it forces the healthy protein to misfold as well. It triggers a cascading chain reaction of destruction.
It literally turns the brain tissue into a sponge, right?
Yeah.
Spongiform encephalopathy.
Exactly. It creates microscopic holes in the brain tissue. As this rapid deterioration occurs, the complex inhibitory pathways that regulate reflexes are destroyed. The startle response becomes wildly exaggerated as the brain's architecture physically dissolves.
Okay, so we have covered a massive amount of medical ground here.
We really have.
Let's actually map this out on a mental whiteboard. Just to cement this in your memory, we'll do 2 quick diagrams.
I love that idea. Visualizing the process helps so much.
Okay, so first, let's draw a simple process diagram in our minds. Normal versus pathologic.
Let's do it.
For normal, picture this sequence. Trigger is an unexpected gunshot. Draw an arrow to normal sensory processing in the brainstem. Draw an arrow to brief motor flinch.
Very clean, very safe.
Now below that, the pathologic sequence. Trigger is a minor tap on the shoulder. Draw an arrow to faulty processing, which is either a hyperactive autonomic state or a broken surge protector in the brainstem.
Right.
Draw a final arrow to the outcome. Grimace, flexion, abduction, and fall.
That's a great process diagram. Now let's draw a flowchart for clinical decision-making.
Take it away.
Imagine you're the doctor. The top of your flowchart is exaggerated startle.
Okay.
Draw an arrow down the first decision point. Check baseline state.
Right. Look at them between startles.
Exactly. Now draw 2 branches coming off that.
Yeah.
The left branch's baseline state equals tremulous and anxious.
Our bucket 1.
Yes. Draw an arrow down from that to your diagnoses. Think PTSD, withdrawal, caffeine, GAD.
The hot engine.
Perfect. Now the right branch. Baseline state equals normal.
Bucket 2.
Draw an arrow down from that. Think hypercaplexia, brainstem lesions in the pons or medulla, CJD, TBI.
That is a highly accurate diagnostic map. But in medicine, knowing the map isn't enough, is it?
No, it's really not.
You also have to know where the map might trick you. You have to know what else looks like pathologic startle but is actually a completely different disease.
The mimics. The differential diagnosis.
Exactly. If a doctor sees a patient jump violently at a loud noise, what else could it be?
The primary mimic that must be differentiated from pathologic startle is a condition known as startle epilepsy.
Startle epilepsy, so a seizure triggered by a fright.
Exactly. It falls under the category of reflex epilepsies, where a seizure is consistently provoked by a specific external stimulus.
And in this case, that stimulus is a sudden surprise or loud noise.
Right.
So how does a doctor tell them apart? If both patients hear a loud noise and collapse to the floor, how do you know if it's a damaged brainstem surge protector or an epileptic seizure?
The absolute most critical distinction lies in the nature of the physical movement itself. The major feature of startle epilepsy is not an exaggerated flinch or a complex reflex. It is a tonic seizure.
A tonic seizure. Let's define the mechanics of that. A tonic state means muscle tone becomes absolute, right? The muscles suddenly and completely stiffen.
Right. An epileptic seizure is essentially an electrical storm in the brain, a massive synchronized misfiring of cortical neurons.
So not a short circuit in the brainstem, but a storm in the cortex.
Exactly. When the startle triggers this storm in startle epilepsy, the electrical surge locks the muscles up. The patient's body becomes completely rigid. They might cry out as air is forced from their lungs, and they fall over like a statue.
Okay, that is a huge difference. In pathologic startle, we saw complex, almost chaotic action, the face grimacing, the body crunching inward, the arms bending and flying outward simultaneously. It's a violent movement.
Very dynamic.
But in startle epilepsy, it's a rigid locking up of the entire body.
Precisely. That is the clinical differentiator, action versus rigidity. Furthermore, the patient profile is usually very different. Startle epilepsy mostly has an onset in childhood. Specifically, it is most often seen in children who are multiply handicapped and who already suffer from other types of spontaneous seizures.
Oh, I see.
The startle is just one of many triggers for their underlying epilepsy.
Let's create a memory anchor for you listening right now, a mnemonic of sorts. Action versus seizure.
I like that.
If the startle causes an action like grimace, flexion, fall, think pathologic startle. If the startle causes the body to lock into a rigid seizure, think startle epilepsy.
That is the exact clinical reasoning a neurologist would use.
Okay, we've covered the typical presentations, the deep anatomy, the neurochemistry, and the mimics, but there is a completely unique, totally fascinating subset of this condition that we have to talk about.
Yes.
This is where neurology intersects with sociology and history.
You are referring to the culture-bound syndromes of pathologic startle.
Yes. This genuinely blew my mind. The literature details groups of people who are normally quiet, completely typical individuals. But when they're startled by an unexpected stimulus, they don't just exhibit the physical flinch.
No, they do much more.
They also immediately exhibit highly distinctive, complex, voluntary behaviors like aggressive cursing, swearing, and echolalia.
Echolalia being the involuntary parrot-like repetition of another person's vocalizations or words.
Right.
If you say drop the glass, they will instantly say drop the glass while startling.
It sounds almost theatrical, but it is a documented medical phenomenon. Let's look at the historical context of the first famous group, the jumping Frenchmen of Maine.
This is a classic case study in neurology, first widely observed and documented in the late 19th century by an American neurologist named George Miller Beard.
He traveled up to the remote, isolated lumberjack camps in northern Maine and observed these French-Canadian loggers.
And what did he find?
He found that if a loud noise happened, say a tree cracking unexpectedly or someone dropping a heavy tool behind them, certain lumberjacks would experience a massive physical startle.
The pathologic startle.
Right. But it was immediately followed by an intense, uncontrollable stream of swearing, or they would instantly obey any sudden command shouted at them during the startle.
Which is fascinating.
Yeah, if someone yelled, "Strike!" right as a loud noise happened, the startled lumberjack might throw whatever was in his hand.
And this phenomenon isn't isolated to 19th century North America. The literature introduces two other globally distinct yet neurologically and behaviorally identical syndromes.
Where else?
In Malaysia, a virtually identical presentation has been observed primarily in adult women, and it is culturally referred to as lata.
Lata. And in Siberia, isolated groups of residents exhibit the exact same pattern, a severe startle immediately followed by echolalia, copying movements or swearing, and there it has been termed miriachet.
From the logging camps of Maine to the villages of Malaysia to the frozen expanse of Siberia. Geographically entirely disconnected, but neurologically identical.
Okay, I have to stop and ask a deeply philosophical question here, because this feels like a paradox. We just spent all this time explaining how the startle reflex is a primitive, involuntary brainstem reaction.
Right.
It's a broken surge protector or a lack of GABA. It is biology. How can a geographic location or a specific culture dictate a highly complex behavior like swearing in French or repeating a specific local phrase that seamlessly follows an involuntary reflex?
That's a great question.
Because a reflex is biological, but swearing is a learned cultural behavior.
It is the defining paradox of these syndromes, and it gets to the very heart of why they're called culture-bound. The medical texts explicitly note that these secondary actions, the cursing, the echolalia, the obedience to commands, are generally considered voluntary behaviors.
But they happen in the exact millisecond after the shock. They don't look voluntary.
This forces us to explore the incredibly blurry, microscopic line between an uncontrollable brainstem reflex and a culturally conditioned release of frontal lobe inhibition. We have two systems interacting here.
Okay, break that down.
The physical startle, the broken insulation in the brainstem, or the hyperactive autonomic state, that is the biological reflex. The shock to the system is completely involuntary.
But the reaction to the shock is shaped by the environment.
Exactly.
Yeah.
Think about the frontal lobe of your brain. Its main job is executive function and social inhibition.
Okay.
It's the part of your brain that stops you from screaming when you are angry or swearing in a quiet room. It filters your impulses to match cultural expectations.
The social brake pedal.
The social brake pedal, yes. Now, when a massive pathologic startle occurs, it creates a momentary profound disruption in the brain's circuitry. The sheer volume of the electrical surge essentially overwhelms the frontal lobe for a fraction of a second.
Wow.
The cognitive filters are momentarily dropped. The social brake pedal slips.
Oh.
In that microscopic window of lowered inhibition, a highly conditioned, perhaps culturally specific suppressed response simply slips out.
So, in the hypermasculine, rugged, high-stress environment of a 19th century logging camp, the suppressed impulse might be intense profanity.
Right. And in other cultures, it might be the repetition of the last word heard. The startle doesn't create the swearing. The startle momentarily removes the barrier that was holding the swearing back.
It's like the physical reflex violently kicks open a behavioral door in the brain, and whatever culturally suppressed behavior is waiting behind that door just spills out before the conscious brain has time to slam it shut again.
That is a very elegant way to describe a phenomenon that has puzzled neurologists for over a century. It highlights a profound truth about medicine. We are not just biological machines running on electrical wires.
No, we're not.
Our neurology is intimately intertwined with our environment, our stress levels, and our sociology. The brainstem controls the jump, but the culture influences what comes out of the mouth when we land.
It is truly wild. But whether the pathologic startle results in a violent fall to the ground, a rigid electrical seizure, or a stream of 19th century lumberjack curses, the doctor sitting in that consultation room ultimately has a job to do.
Yes, they do.
They have to offer the patient relief. How do you treat a broken startle reflex?
The clinical approach to managing pathologic startle is highly logical, but it requires strict adherence to order. Step 1 is the primary rule of all good internal medicine. Treatment must be directed at the underlying cause.
You don't just treat the flinch, you fix the foundation. You figure out which bucket they're in, and you attack the root.
Precisely. If the patient is in bucket 1 because their nervous system is vibrating from alcohol or sedative withdrawal, you manage the withdrawal safely with medical detox.
Right.
You give the brain time to rebuild its GABA receptors. If the cause is PTSD, you treat the psychological trauma and the hypervigilance through therapy and targeted medications to calm the amygdala.
And what about bucket 2?
If the patient is in bucket 2 because an ectatic swollen artery is physically pulsating and compressing the medulla, the patient may need neurosurgery to move that vessel and address the mechanical compression.
Wow, neurosurgery for a startle.
It can happen. If a stroke caused an infarction in the pons, you manage the cardiovascular risk factors to prevent further damage. You must first attempt to remove the trigger.
But what if you can't? What if the underlying cause is hyperplexia, a genetic defect in the glycine receptors that you are born with?
Yeah.
Or what if it's permanent, irreversible damage from a traumatic brain injury or a multiple sclerosis plaque that stripped the myelin away forever? What if treating the root cause is medically impossible?
That leads us to step 2 of the protocol. When treating the underlying cause is ineffective or impossible, a trial of a specific pharmacological medication is indicated. Clonazepam.
Clonazepam. Let's dig into the pharmacology here because it brings everything we've talked about full circle.
Nah.
Clonazepam belongs to a class of drugs called benzodiazepines.
Yes.
It is a powerful sedative.
It is. And we need to look at exactly how it works on a cellular level. Clonazepam binds directly to the GABA-A receptors in the brain.
GABA, the exact same inhibitory neurotransmitter we talked about earlier, the brain's natural braking system.
Exactly. When clonazepam binds to that receptor, it forces the ion channels in the neuron to open wider and stay open longer. This floods the neuron with negatively charged chloride ions.
And a negative charge makes it much harder for the nerve to fire an electrical signal, right?
Precisely. It hyperpolarizes the neuron. It essentially wraps a heavy chemical blanket over the hyperactive or damaged circuitry. It artificially lowers the excitability of the entire central nervous system.
So it makes perfect logical sense. If the system is running too hot because of anxiety, or if the brainstem wires are stripped of their myelin and sparking uncontrollably, or if the genetic glycine receptors in the spine are broken, you administer a powerful GABA agonist like clonazepam.
Yes.
It acts as an artificial shock absorber. It calms those hyperactive pathways down and raises the threshold for that startle response back up to a normal level.
It restores a measure of pharmacological inhibition to a system that has lost its natural biological inhibition. It raises the threshold so that the falling leaf no longer triggers the blaring siren. The brain can finally process a gentle tap on the shoulder as exactly what it is, harmless.
Man, this has been an incredible journey.
It really is a fascinating topic.
Let's do a quick self-test section and rapid revision just to make sure all of this sticks for you listening at home. I'm going to fire off 3 questions, see if you can answer them in your head before I give the answer.
This is great for active recall.
Question 1. What specific arm movements happen during a severe pathologic startle?
Think about the tap on the shoulder.
The answer: flexion and abduction, bending in and flying out.
Right.
Question 2. What is the first clinical feature you look for between startle episodes to determine the cause?
Our 2 buckets.
The answer: persistent autonomic hyperactivity like anxiety or tremors. And question 3. If a child with multiple handicaps has a tonic seizure after a loud noise, what is the diagnosis?
Action versus seizure.
The answer: startle epilepsy, not pathologic startle.
Excellent.
Yeah.
And for a rapid revision summary, pathologic startle is severe, frequent, and provoked by minor stimuli.
Right.
The diagnostic fork in the road is checking for baseline autonomic hyperactivity. If it's present, think withdrawal, PTSD, or stimulants. If the baseline is normal, think brainstem lesions in the pons or medulla, or a genetic condition like hyperechexia.
Perfect.
Don't forget the culture-bound mimics like the jumping Frenchman, and remember the treatment protocol. Fix the root cause first, and if you can't, use clonazepam.
That is a perfect 60-second summary. As we wrap up this deep dive, I want to leave you with one final thought to mull over. Think about that normal startle reflex again.
Yeah.
It is designed to keep us alive in a dangerous, unpredictable world. It is the shield that protects us before we even realize we need protecting. But when that internal wiring shifts even microscopically, that very survival mechanism goes completely rogue.
It really does.
It turns a harmless, everyday interaction into a catastrophic, body-collapsing event. The line between a perfectly functioning survival instinct and a severely disabling neurological disease is microscopically thin. The shield literally becomes the weapon.
It is a humbling reminder of the fragility of the human nervous system.
It really is.
You know, the next time a door slams a little too loudly near you or a dog barks unexpectedly on the street, take a moment to notice your own normal startle reflex.
Yeah, feel it happening.
Feel the quick intake of breath, the brief tension in your neck and shoulders, and then the immediate relaxation as your cortex tells your brainstem that everything is okay. And as you feel that adrenaline fade, take a second to appreciate the intricate, silent, perfectly balanced neurobiology that is working tirelessly to keep that massive electrical reaction safely in check.
That's a really great perspective. Thank you for joining us for this deep dive into the fascinating world of pathologic startle. We will see you next time.